So, welcome to the Seeing is Believing Africa Regional Webinar. My name is Susan Evans and I'm the Seeing is Believing Project Officer for IAPB. Thank you all for attending today. I hope you and your families are all keeping well during these challenging times. I'm aware that COVID-19 has impacted all of our lives and I really appreciate you taking the time to join us and be part of our learning community. The theme for this SiB webinar is Child and School Eye Health, and we have some fantastic presentations for you. We have over 100 people registered from 10 countries in the region, which is great. Our audience today are SiB project implementing partners, and for the first time, we've opened up our SiB webinars to the wider IAPB membership. So if this is your first Seeing is Believing webinar, you are highly welcome. And if you've attended before, it's good to see you again. If you would like to introduce yourself to the group today, you can write your name and which country you're from in the Q&A. I would like to give a big thank you to our webinar presenters. Dr. Anne Ebri, the Sub-Regional Manager at Brien Holden Vision Institute. Hi, Anne, do you want to say a quick hello?
Hi.
Thanks, Anne.
Thank you for having me.
Always a pleasure. Andrew Ware, CBM UK Head of Programmes with CBM.
Hi, nice to be with you all today.
Thanks, Andrew. Simon Day, the Africa Regional Coordinator for IAPB.
Hello, everyone. Thank you for having me.
Sally Crook, the Seeing is Believing Programme Manager with IAPB.
Hello, everybody. I think I know lots of you, or hopefully I know lots of you out there.
And Dr. Naomi Nsubuga, the Sub-Regional Manager for Eastern Africa for Brien Holden Vision Institute. Now, Naomi's not with us just yet, but we're hoping she's going to join in a little bit. So the agenda for the webinar today will be welcome and housekeeping notices from me, an introduction to the opportunities and challenges of child and school eye health in the Africa region, and that's with Simon Day. First presentation on child and school eye health in the CBM BHVI Nigeria Child Eye Health Seeing is Believing project by Dr. Anne Ebri and Andrew Ware. The presentation on child and school eye health in the BHVI-led East Africa Consortium Child Eye Health SiB project by Dr. Naomi Nsubuga. After the presentations, I will chair a question and answer session. And then finally, Sally Crook, SiB Programme Manager, will make some concluding remarks. And the webinar should take around an hour. So firstly, some housekeeping points. So each presenter will share their screen during their presentation. Microphones are muted apart from the speakers, as this ensures a better quality webinar. We aim for this session to be participatory, so if you have any questions for the presenters, please type them in the Q&A box. My colleague Rachel is supporting us today with technical issues. So if you have any technical difficulties, for example with sound, you can send us a message in the Q&A. And thank you, Rachel, for your support today. It's a good idea to close down all other web applications, for example, Google, Outlook, Skype, to get a better quality of call. And if you have headphones, please use them. I'm recording this webinar and it will be uploaded onto the IAPB website, and I will send around the link in a few days. And finally, at the end of this webinar, I will be sending you a survey for your feedback. So as mentioned, the theme of this SiB webinar is Child and School Eye Health. The presenters will share their learning from implementing child and school eye health SiB projects, and we hope that listeners will be able to identify strategies you will be able to implement in your own contexts. We are aware that due to COVID-19, many eye health activities are suspended and schools are currently closed. In her concluding remarks, Sally Crook will share some resources on child eye health and COVID-19. I'm now pleased to introduce Simon Day, the Africa Regional Coordinator for IAPB, to give an introduction to some of the challenges and opportunities of child and school eye health in the Africa region. Simon, over to you.
Thank you, Susan. Child eye health is a significant public health issue, particularly in low and middle income countries, and requires well-integrated strategies to address the growing need. The consequences of inaction range far beyond vision, affecting education, social participation, and future economic productivity. Primary school education is at the base of the pyramid of education and is regarded as a fundamental human right. As an essential component of human capital, primary education plays an important role in the economic growth and development of a country. The challenge is to provide conditions which meet the basic needs of children, particularly in health and education. This places a significant responsibility on the education and health sectors. Education has the potential not only to change individuals' lives, but to fuel fundamental social transformation. School health addresses multiple needs of school-aged children across an age span of 12 years and encompasses many different kinds of health interventions. Its successful implementation is dependent on the integral collaboration of multiple sectors and manifold levels and components of the health system, a feat that requires skillful management and leadership. In some countries, however, in Africa, a picture that emerges is a deprioritized school health service with a universally poor coverage that is inadequately resourced, poorly understood, and largely unsupported by managers across all levels of the health system. Other factors can contribute to poor policy performance around school health. For example, systematic factors such as the immaturity of the district health system, general nursing staff shortages, and a relative lack of referral services. There are also school health specific factors such as poor relationships between key stakeholders in the particular departments of health and education, poor relationships between parallel health initiatives aimed at schools, namely that between health promoting schools and school health, a lack of transport for this community-based outreach service, and poor managerial understanding of and support for the school health service. School health programs are a unique opportunity to provide comprehensive eye health services to potentially more than 700 million children throughout the world. Looking to the future, this number will only increase, especially in low-income countries, due to the combined effect of the population growth and increasing provision of primary and secondary education. There are initiatives to improve health through schools, such as promoting school initiatives, such as health promoting school initiatives, deworming, and control of other neglected tropical diseases. These initiatives provide an opportunity for integrating eye health, hence increased sustainability and coverage. Access to eye health care for an increasing number of school-aged children is critically important for at least 4 reasons. First, it is a golden opportunity to deliver eye health education messages ranging from hygiene to healthy diet and outdoor activities to prevent trachoma, vitamin A deficiency, diabetes, and high myopia. In that respect, eye health have a long-term sustainable impact on both individuals and communities. Secondly, early detection and referral of children with eye problems is key to timely provision of highly cost-effective interventions, such as the provision of glasses. School-based screening programs allow for an early detection of conditions that cannot be cured but require appropriate low vision services. These include inclusive education to ensure that each and every child can achieve his or her full potential. This further contributes to the social and economic development at individual and community level. Thirdly, irritated, sore, light-sensitive eyes significantly impede children's ability to learn and may lead to the use of harmful practices, which can further damage the eyes. In some areas, eye morbidity represents a significant cause of school dropout. The detection and treatment of common eye conditions, such as conjunctivitis and lid infections, are a critical part of child-centered, comprehensive school health problems. Fourthly, considering that an estimated 80% of what a child learns is processed through the visual system, good visual is critical to the child's ability to participate in and benefit from education experiences. In that respect, improving the vision of school children contributes to improved educational status, which in turn leads to better health in adult age. It is anticipated that the implementation of child eye health within school health approach will enable a more comprehensive and integrated approach for sustainability and scalable child health programs and greater efficiency and cost effectiveness. Thank you.
Thank you, Simon. Just finding out where my unmute button was. Thank you for that really kind of thorough and comprehensive introduction to this really important topic. And it was really interesting. Thanks so much for that. And we have Naomi on now. So I will also introduce Dr. Naomi Nsubuga, the Sub-Regional Manager for Brien Holden Vision Institute. Hi, Naomi, how are you?
Hello, everybody.
Hi, thanks. Right, okay, great. Thanks, Naomi. I'm glad you could join us. So what we're going to do next is we're going to start with our presentations. So for our first presentation, let me introduce Dr. Anne Ebri, the Sub-Regional Manager, Brien Holden Vision Institute, and Andrew Ware, CBM UK Head of Programmes. And I think, Andrew, you're going to start, aren't you? And then Anne is going to continue. So Andrew, over to you if you'd like to unmute yourself and start sharing your screen.
So it's a pleasure to join you today. I've been head of programs at CBM UK just since last November, so this is quite a new area to me. We have with us Dr. Anne Ebri, who's an expert in the field from Brien Holden Vision Institute. And the way we're going to do this presentation is I'm going to give an overview of the programme as a whole and some of the areas that CBM particularly covered, and then Dr. Anne is going to effectively share a case study of child eye health in schools from 2 states in Nigeria. So the SiB Comprehensive Child Eye Health in Nigeria programme was a 3-year programme implemented in 11 states in Nigeria. It was led by Dr. Juliana Nathaniel, who would have been far better qualified than me to do the presentation, but sadly her role ended when the programme did a couple of months ago. So the programme's overarching aim, as here on the slide, was to contribute to reducing avoidable blindness and visual impairment through providing comprehensive child eye health services to 1.5 million children across selected states of Nigeria. We were working in 11 states. Now, inevitably, the assessments and baseline study revealed a number of challenges to this programme, not least a weak health system and poor service delivery, both in terms of the quality of service but also availability of services. We also found there to be ineffective leadership and coordination of services, including data management, and there were inadequacies with the skill levels of the human resource for eye health. There was also low levels of eye health finance and inevitably lack of equipment, drugs and medical supplies in many of the facilities. We also found that there were multiple barriers to communities being able to access child eye health care. This partly led to poor eye health seeking behaviours, and the barriers included geography, socio-economic barriers, low levels of awareness, and also a high level of misconception and myths among community members about eye health issues, which Simon touched on just now. And the situation was particularly bad amongst rural and poor families. So we took a strategic approach and addressed this in the design. So the first approach we took was identifying gaps in the healthcare systems and adopting measures to increase access of vulnerable children to quality eye health in those communities. Another key strategy was positioning the eye health unit within the Federal Ministry of Health. This enabled us to establish, direct and coordinate policies and guidelines for effective delivery of the Comprehensive Eye Health Programme. Similarly, we integrated eye health services into public health centres, building the capacity of healthcare workers and improving health facilities, equipment and supplies. Also, we supported the government of Nigeria, working very closely with them to develop eye health indicators, and we embedded eye health into the National Strategic Health Development Plan. An important part of this was developing eye health data, capturing tools, and setting up a health system platform to support the collection, collation and analysis of eye health data across the country. And finally, but no means least, we engaged in strategic advocacy and behaviour change communication activities in order to leverage resources and improve community health seeking behaviour. So there were in total 6 objectives of the programme. I'm going to focus in particular on 4. Anne's going to go into a lot more detail on the 5th, and I'll just touch on the 6th. So the first objectives firstly covered developing skilled and adequate manpower, personnel to provide comprehensive child eye health services in the target areas. So this involved training healthcare workers at facility and community levels for quality case identification, referrals and delivery of eye health care. Secondly, we work to improve the quality, accessibility and scope of eye health services for children. So we sought out high impact strategies to ensure that service delivery targets were met. Our overarching target was reaching 1.5 million children with eye health services ranging from basic screening through to cataract and other surgeries. And in fact, we were pleased to be able to reach 1.67 million children during the programme. The child eye health services themselves were provided by trained healthcare workers in a total of 275 healthcare facilities, mostly primary facilities, but also selected secondary and tertiary level facilities in the target areas. And then finally, our strategic behaviour change communication and combined with a multi-pronged information campaign helped to reduce myths and misconceptions around eye care and eye health and increase acceptance and utilisation of those services. So on to the 3rd objective. This was around embedding child eye health into government policies and programmes, working very closely with the Ministries of Health and the Ministry of Education. Under this objective, we found that partnering and advocacy were key approaches. And so we developed the guides and manuals very closely with those 2 ministries. And you'll see in the table just 6 of the different guidelines and manuals that were developed during the course of the programme. So objectives 4, 5 and 6. So objective 4 was in many ways a sort of specialism of CBM. We piloted strategies for inclusive eye health. The rationale for this was that the baseline study revealed, in fact the assessments and study revealed that healthcare workers were largely ignorant about children with disabilities. And we also found, partly as a result of this, that this extremely vulnerable group were excluded from eye health services due to barriers of stigma, physical, institutional barriers, and communication. So we developed a number of strategies and new activities in 2 pilot sites to bridge the gaps that had been identified. And the N-line study revealed that interventions had been particularly effective. Awareness of disability inclusion was much increased, with a more positive experience of services reported by children and adults with disabilities. Barriers had been addressed, leading to increased access to eye care by those children. The 5th objective covers the establishing of school eye health programme, and this is the particular area that Dr. Anne will be sharing with us shortly, so I won't talk any more about that. And then the 6th objective is around improving quality and early intervention and education of children with severe visual impairments and blindness. We worked closely with government institutions, NGO institutions and schools to achieve this, but due to time constraints, I won't actually elaborate on that section any further. So on to learning from the programme. The evaluation, the N-line evaluation, found that strategic investment in capacity building for health and school workers for comprehensive eye health services did indeed achieve remarkable improvement in the target communities. Progress has been made around improved knowledge on eye health issues and also improving health-seeking behaviour. Overall, there was a noticeable increase in the coverage of primary eye health care in the study locations. However, concerns remain that a shortage of health staff does present potentially a barrier to continued improved eye health. We also learned, as mentioned, that successful execution of the pilot for inclusive eye health has resulted in blind and visually impaired boys and girls being reinstated into schools or attending schools for the first time. And then final learning was that whilst the SiB programme has been well embedded into the Ministries of Health and Education, policies are yet to be fully adopted at state and national levels. So there is still some significant work to do there. So on to my final slide with conclusions and recommendations. We certainly found that taking a strategic approach to identifying and addressing gaps in eye health services has been largely successful and impactful for this 3-year programme. However, the evaluation did find that eye health services in Nigeria are unfortunately largely remaining as an NGO-driven initiative and somewhat ignored by government, although this programme did significantly help to contributing to a change in that attitude. However, if that situation persists, we would recommend inviting the private sector operators to consider developing affordable schemes for eye health care to supplement government provision. We also came up with some other recommendations, including providing routine eye checks as part of the admission process at schools, and also for children who have other reasons to visit health facilities to obviously carry out checks whilst they are there. A great deal of training was provided, and upskilling of the health and, for that matter, teaching workforce, and refresher courses are needed to retain the knowledge gained. We also found that awareness raising campaigns had been very successful, but they will need to be repeated regularly to sustain the impact of those campaigns. So that wraps up my presentation, and I believe that Dr. Anne's now going to take over And I believe that Susan's going to take us through her slides. So thank you very much.
Thank you, Andrew. Yeah, you should be able to see my, can you see my screen?
Yes, I can.
Yes.
Okay, great.
All right.
Lovely.
Thank you very much. Can you hear me?
Yeah, loud and clear.
Thanks so much, Andrew, for laying out the presentation and making it easy for me. I would be speaking on a case study within the broader SiB Child Eye Health program, which was a comprehensive child eye health program funded between 2017 to 2020. And as Andrew mentioned, one of the objectives was to establish the school eye health as a sustainable model to deliver eye health services to children. So in one of the clusters, the cluster 4 that was led by Brien Holden Vision Institute, I was the project manager. And so I'll just share briefly the strategy that was used to establish that. So evidence-based approach was one of the important elements that laid out the strategy. Number one, that uncorrected refractive error still remains a common cause of visual impairment among school-going children, and the prevalence is as high as 8% for children below 11 years, and even higher for children above 11. And we also found out that the most prevalent eye conditions amongst the younger children, the ones in primary school, were non-refractive error, not refractive error actually, but allergic conjunctivitis, corneal opacities, and other simple eye conditions that can be managed. Next slide, please. So the objective was to establish the school eye health program, as I mentioned, as a sustainable model. And it was carried out in 2 states, 2 out of the 11 states that we worked on. And as mentioned earlier, the major challenges were the limited number of nurses and the absence of school nurses in this environment. And we also found out that, of course, as mentioned in Andrew's presentation, that it was uncoordinated and not a mainstream priority for government. Next slide. So the strategy was to utilize the available eye care personnel in the public sector and to develop a team that can deliver a coordinated and effective school eye health services, targeting the most vulnerable and also utilizing the available research data that we have. Next slide. So they were divided into 2 approaches. We have the secondary school approach and the primary school approach. The secondary school approach, we found children that were as young as 9 years and older in secondary school. So we decided to focus on identifying significant refractive errors amongst this population. So eye screening was conducted by the teachers that have been trained by optometrists. Optometrists trained the school teachers, and not all teachers, only form teachers. The form teachers were able to screen 30 to 40 students. This is quite a manageable number. They were provided with the tumbling E's, the 5 tumbling E's that has a visual acuity of 612 rule, and also provided with a 3-meter twig to make sure that the distance was accurate. And they were also given pen touches to do a quick external eye assessment. So these form teachers were able to carry this out during an extended break period. And children who failed the screening test were issued referral letters through their parents for a full eye examination at the centers that have been equipped with trained personnel by the project. And we had 8 of those centers in both states, 4 apiece. And children who required refractive error correction were provided spectacles, and those who required other forms of treatment, like some who had cataracts and all that, were also managed within the secondary centers, within the hospitals. Then the primary school approach, we found children as young as 4 years and up to 11 years in the primary schools. So this approach involved ophthalmic nurses. Ophthalmic nurses are already trained ophthalmic nurses, but they were still given some training to understand what to expect in children in primary school. And they visited in teams. They were located and assigned to their area of assignment, and they had with them pen touches and eye drops. Simple eye conditions like allergic and bacterial conjunctivitis were identified by these teachers and treated right there at the school. And treated, what I mean by treated, that is they issued out the eye medications appropriate to the eye conditions, and then handed out instructions so that parents could apply the eye drops at home. And then children who self-reported eye problems were identified, and there were some children with refractive errors, even in primary school, that suspicious conditions. All those cases were given referrals to the hospitals for full eye examination. Next slide. So we found out that this strategy was quite simple and effective. And within the months of March, April, and June, nearly 200,000 children had been screened, achieving an increase of about 68% of the total project output at the time. And eye medications were effectively dispensed to children with, in both states. About 11,000 children had been taken care of. And 2,300 spectacles were also dispensed, which increased our output. And we also found out that both approaches targeted prevalent eye conditions at different age groupings and at different levels, which proved to be quite effective and able to identify children who are most at risk. And then the available skilled personnel, eye care personnel, were engaged appropriately so that they maximize their skills where they were assigned to. And that this model minimizes over-referrals, and we believe that it's a viable option for government to adopt in the absence of school health nurses. Next slide. So in conclusion, and also to recommend the fact that we found out that a higher proportion of children with significant uncorrected refractive errors were achieved. Then children in primary school, as I discussed, I mentioned, were provided immediate management of simple eye conditions and did not need to go to the hospitals, which is usually unlike what obtains with the traditional mass eye screening that overloads the hospital system. And then the strategy also, we found out that teachers, ophthalmic nurses, and optometrists, being government employees, can be used or can be effectively engaged in eye care in such a way that it will sustain eye care service delivery through periodic visits to schools. Government already has ongoing programs like deworming programs where schools are visited by Ministries of Health. So we have recommended to government that all they need to do is to add on the certain aspects of the screening for primary schools to identify the eye condition, so that children who are given tablets for deworming, it's a quick look at their eyes to see if the eyes look abnormal. And we also want to add on to the outreach programs that are ongoing, funded by government hospitals periodically for the secondary hospitals, where doctors and optometrists can actually attend to children at those hospitals, and incorporate school eye health programs, so that certain schools will be assigned to certain secondary eye health teams, where periodically that can happen, where teachers will continue to send referred cases to the hospitals. I guess that's about the last slide. Any other one? All right, thank you.
Thank you, Andrew and Anne, for that overview of your approaches to child eye health and the project in Nigeria, and some really interesting ideas around, you know, the different approaches for primary and secondary, and just how efficient that is in terms of, you know, ensuring children get the right treatment at the right level, and also great to be embedding in existing programs. So thank you for that. Okay, so I would now like to introduce Naomi Nsubuga, the Sub-Regional Manager, Eastern Africa for Brien Holden Vision Institute. So Naomi, would you like to unmute and then share your screen? Yeah, I can see your screen, yeah.
Okay, great. Thank you very much. I'm going to be talking about the East Africa Child Eye Health Project. This is a project that took place some time back from 2013 to 2016. This was a multi-country, multi-consortium project, which was quite large. We had 2 consortia implementing. The Brien Holden Vision Institute consortium was assigned to implement at the primary level, that is from community to district, and then the CBM-led consortium was covering the secondary and tertiary levels. And we're working in 3 countries, Kenya, Tanzania, and Uganda, across some counties, and the districts or counties where we're working. And these were selected to match with the clusters that the secondary and tertiary level were, because we wanted to ensure there was a continuum of services from the community level all the way up to the tertiary level. So in Kenya, we're in 8 counties, which were in one of the clusters. In Tanzania, we're covering 2 clusters, the Mwanza region and the Mbeya region. And in Uganda, we managed to have a district within each of the 4 clusters that the consortium was implementing in. We had 9 members in the, which as I talk in the, as we come along, I'll let you know that in the beginning was a little bit tough, but the reason the number was varied and the selection is that every organization brought on a specialized skill. So there were those who were strong in advocacy, those who were strong in primary eye care, those who were strong in school eye health or child eye health, etc. And then of course the professional associations, which were involved in the technical support, and the one university which was signed on to provide training for pediatric refraction and low vision. The project goal was to reduce the percentage of avoidable blindness and visual impairment in selected regions of 3 East African countries, Kenya, Uganda, and Tanzania, over 4 years through the development and implementation of a comprehensive child eye health program, directly reaching an estimated population of 4 million children, aged 0 to 15, leading to improved quality of children's lives and educational performance. We were questioned a lot when we went into the schools why we chose 8 to 15, because on the education side, a child is 0 to 18. So we had to explain that a lot. But I think in the end, they understood, we made the point on why we're working from 0 to 15. And this also kept us in working in primary schools. So we could not go into the secondary schools, because that would have meant just seeing some of the children and not the rest of the children in the school, again, which would have created a little bit more confusion and questions from our local implementers and stakeholders. The objectives of this project, the first one is to improve the quality of eye health services and access for all children aged 0 to 15 years. With this one, we result of capacity building on the health and education side, equipping facilities and supporting the general health and education sector. Number 2 was to establish the school eye health program as a sustainable and efficient model of delivering eye health services to children. Number 3 was to improve the quality of early intervention and education of blind and visually impaired children by ensuring that the children receive necessary specialized educational support. As mentioned in the previous presentations, these children who are visually impaired and blind have not been really thought of when services are going out. Very few organizations are equipped and qualified to be able to support these services for these children. Number 4 was model strategies for promoting child eye health in East Africa, documented, published, and replicated. And number 5, child eye health is increasingly embedded in the policies and program work of the Ministries of Health and Education. So these are the achievements. Just to give you briefly, the capacity building, where we're working with optometrists and OCOs. Only Tanzania had optometrists available. Kenya and Uganda were working with OCOs. That's the eye care cadre that was available in the government structure, in the health facilities that we're supporting. Then of course, supported the ophthalmic nurses and assistants. Maternal child health workers and general nurses were key for the children who are not in school. And the maternal child health workers part where they added on the child eye health activities. The community health workers were very supportive in identifying in the community and referring to the nearest health facilities. These maternity child health workers and general nurses were in the facilities below the district level, the health centers, so where the people sometimes first go to get services, and then they can be referred upward, up to all the way to the district level if needed. Teachers for sighted children, these were mainly the 6 to 15 group, and we trained 2 teachers per school. And Uganda was a little bit different from the other 2 countries in that we added the head teacher as well. And we found that made a difference in getting buy-in from the teachers. Otherwise, the teachers were not really interested in this thing, because you are getting somebody from the health sector to train the teachers, but then it is very hard to enforce follow-up and data collection and things like that. Then we also taught teachers for visually impaired and blind children, and this was one of our partners, Parkins, played a key role in this. Again, it applied to both the children in school, but also the preschool children, where we worked a lot with the parents as well. And then we also added on the peer-to-peer advocacy group, which is child-to-child advocacy. We named them the Vision Champions. And this one, we had done some research prior to this project, and we found it was successful, that children were very good champions of eye care. Service delivery, our target was 4 million, and we managed to overachieve. Was 1 million per country, plus a few of the other beneficiaries who were not directly from the school screening, but came through other means. And over 80,000 children received primary care treatment. And as mentioned by Anne, we found a lot of allergies. This is something that people were not aware of until we went in and found a lot of children who had allergic conjunctivitis, and a few of them with the bacteria, and all of them received treatment. We found about 9,000 children needing spectacles and received them, and over 900 children received devices, as well as children who were blind, were either they were already in special schools or were referred to and integrated into special schools to receive the support there. And 20 units were equipped across the 3 countries. So based on the outcomes, so I think I'd started on the outcomes. So like I said, we were working within the government structures with government workers and supporting, primarily at the beginning, we worked with government schools. The second outcome, we're looking at integrating the child health into the national school health programs, maternal and child health programs, and broader development and disability agenda. We managed to review all the school health policies in 3 countries, and 2 of the 3 countries were successful in getting it on through the project. In Kenya, we're still reviewing it. We also managed to review, to present when they were reviewing the midwives curriculum in Uganda, to see how they can include child eye health in there, and as well as introducing the pediatric refraction and low vision training as a certificate course at Masinde Muliro University in Kakamega in Kenya. And Perkins was generous enough and took 1 teacher per country to undergo an education leadership program training for teachers so that they could come back and continue the work that we were doing. As you can see in the pictures on the right, the middle picture on the right, that is maternal child health workers. These mothers have brought their children for immunization, and they're going to get also the child eye health talk, and then also get the eyes checked as well as screened. Number 3, the outcome looked at the importance and need of child eye health. Again, the advocacy was very intense in all 3 countries through IEC materials that were used for the healthcare workers and the community. We developed an advocacy strategy in Uganda as well as clinical guidelines, which helped at a national level. We started off for children, but then we were informed that they actually didn't have any at all for eye health. So we managed to support that through this project. There was a request to start an East Africa Child Eye Health Forum, based on the steering committees that we had during the project. And I'm glad to say that all 3 countries started their own individual child eye health fora. Kenya had 1, Tanzania already had the that we had established from a previous project. And in Uganda, we also formed a Child Eye Health Technical Committee as part of the National Prevention of Blindness Committee. We have not yet made it to the East Africa-wide thing. And one of the biggest successes was the Vision Champions. And in the top right corner, those are the records where the children talked to their fellow students and then wrote down, listed the names of the children who had problems and took them to the teachers who were assigned to screen.
Yeah, I think don't worry about sharing your screen, Naomi. I think the sound will be a bit clearer if you just you can just talk us through the final point.
Yeah,
I think that'd be okay.
Okay. Yeah, that's so basically we're looking at the key learnings for sustainability. The project was generated local ownership, and there's a lot of collaboration now within health and education. We built a good referral network between the schools and the health facilities. There's engagement between the national and then the district level and county level structures, and the support with the equipping the units made sure that the services are continuing, and the children all receive these devices free of charge, except in Kenya where they wanted to put a little surcharge just because they did not want to give free services, but that was something that was discussed and agreed upon. Lessons learned. Project established an equivocal, viable, replicable approach to child eye health in the public sector. There was need to do a systemic and comprehensive review and analysis. We did do that, but we did not look at some of the important development plans. So that was something that we learned, that we make sure we cut across, not just the eye care plan, but successful collaboration and sectoral linkages. We brought in not only education and health, but we brought in disability ministries as well, and also at the district level. And we also learned that to work with teachers, you need to make sure that you go formally through the education sector. Because even though the health workers are the ones training the teachers, but they do not have any control over them to follow up on them. It has to come through the education sector, that they should do that. And when a unified consortium approach provides very efficient planning and management and coordination when you're doing these projects. So we were fortunate that the consortium worked very well, but the good thing is that we did the mapping beforehand and analysis, so we knew the strength of each member, and then we were able to draw on those strengths for the success of the project. Thank you very much.
So you're muted.
Thank you. I'm getting used to Zoom. Thank you, Naomi. That was a great presentation. And one of the things that I really liked about the project and subsequent projects is that sort of really that link with the Ministry of Health and Ministry of Education, really bringing everyone on board to think about what kind of care the children need. So that's been great. Thank you so much for that presentation. Okay, so we're now going to have the question and answer session. So we've had quite a few questions come through already, and I've been reading them as they come, and I'm going to group them per theme. So if you have any other questions for any of the presenters, please do send them through. And I'm aware that we are sort of close to sort of 1 hour, but I think maybe we can kind of stretch for about another 10-15 minutes just to get a couple of questions answered. Obviously, if you do have to drop off, that's fine. So the first question I'm gonna ask is around sort of funding issues around things like, the first question is, were there any kind of incentives to your screeners? And this is for both the projects. So for example, your ophthalmic nurses or teachers, did you have any incentives for them? And secondly, for the medicines for the children or spectacles, was there any cost to the parents, or were these all free or covered by insurance or the project, or how were those covered? So if you could, that's the first question. So Andrew and Anne, do you want to go first? And then Naomi, do you want to go second?
Fine, I can take the one for the things we live in Nigeria. The incentives for teachers and ophthalmic nurses. No, teachers were not given any incentives because they are form teachers, and there were no plans, and they did not receive any. The ophthalmic nurses did not receive incentives, but because they spent time on the field, they were given their transportation, because they were not taken to the field. They were not bused, so they were given transportation and a stipend for lunch, but not incentives. Then for the spectacles and medications were, yeah, they were given free at the hospitals to the children. It was, I think it was the project bore that responsibility.
Thanks, Anne. And Naomi, how about for your project?
For our project, we only gave a transport refund and lunch during the training. When the teachers came to the training, we did the training. We have centers here called coordinating centers, where which in each district there are several centers per parish or sub-county where the teachers come for their continuing education. So those are the centers we used. So it was as if they were coming for continuing education. Then they went back and they went back and did the screening in their schools, and they found time during break time or during PE time, something like that. So apart from when they came for training, we did not give any incentives. Of course, this is a challenge where at the beginning there was some difficulties getting them to perform, because some of them were expecting it, but when the districts came in and informed them that this is part of their duty, they were trained, then they did it quite well. And the inspectors of schools came through and made sure they inspected. We did support the inspectors of schools with fuel to go and inspect schools, as well as our own monitoring. So we had the district take care of that themselves, so that they realized it was not just a project activity, but it's actually now part of their education responsibility. And the data they collected was going to be captured under the Education Management Information System. As far as medication and spectacles, the 3 countries were different. That yes, all the medication was provided. The spectacles and low vision devices in Tanzania and Uganda were provided at the cost of the project. Kenya, like I mentioned earlier, had some cost sharing. And that is something that they said was the decision that the government made, so we could not go against the government decision. But otherwise, everything was provided by the project.
Thank you both. Great. Okay, so then the next question is around sort of what kind of support did you give the teachers for doing their kind of initial screening in schools? So, you know, did they have things like a checkbox, or how did you support them to be able to kind of, what did they need to do in terms of kind of differentiating things like conjunctivitis or infective, or, you know, those different conditions? What kind of support did you give them?
We had a training manual which had photographs, a basic training manual, because we did not want to overstretch the teachers and give them something that was beyond them. And that was one of their concerns, that they might be asked to do something that was beyond them. For them, they were just told to identify key things: a red eye, a white pupil, eyes that are turning, and of course, if they cannot see. So with their training manual, we gave them a screening card, and a tape measure for 3 meters, and a pen torch. So that's what the teachers got. And they had the support of the OCOs, or the ophthalmic assistants and nurses in the nearest facilities, to also give them support. But during the training, that's what we gave them. And each teacher, each set of teachers, or each school received that screening kit: the manual, screener, and tape measure and pen torch. Then they also had referral forms, which are part of the government referral forms. We did not create project-specific ones, where any child who failed, they took that form to the health facility, and they could tear off part of it, which will remain in the health facility, and the other part would go back to the school. So when we did monitoring, we would look for the file. The teacher would show us the files where the children who were referred. If we found half a form, we knew that the child had been seen and had returned. And again, we could check with the health facility whether or not children were presenting by looking for the other half of the form.
Great, thanks, Naomi. And Anne, how about for Nigeria?
Yes, in addition to what Naomi had mentioned, we had all that, the box, the check box to check out how many children have been seen. And the strategy of using the form teachers actually made it quite manageable, because the form teacher is in charge of that class for all purposes. So the form teacher identifies the child, understands who the child is, and sometimes even understands the out of school situation of that child. So it's quite easy for the form teachers to manage that small number of kids, check their eye problems. It's not to make any diagnosis, but to say the black part of the eye is not black, and the white part of the eye is not white. So they have where to tick off easily. And when the recording sheets are collected, and even after the children are seen and sent back to the school, the teachers also are aware of children. We have done a follow-up where teachers mentioned children that have actually been to the hospital and those who haven't. So that small number helps them manage, and they are not under any pressure, to conduct the test in one day. So they can choose to do that over a period of 2 weeks thereafter.
Great, thanks both. And we've got another question around out of school, so out of those children who are out of school. So did you do kind of specific initiatives to kind of reach those children who aren't going to school, or how did the projects kind of deal with that issue? Do you want to, Naomi, do you want to start again, and then Anne?
Okay.
We had, like I said, we had divided the project into 2 sets, the 0 to 5 and 6 to 15. The 0 to 5 were mainly the ones we're looking at out of school, even though in some areas, some of them are already in nursery school. What we did is that the nurses and maternal child health workers were capturing those in the health facilities when they came in for immunization or any other condition. Then the other ones were with the community health workers. If the parent identified a child, or if they found a child who was having any issues, then they would refer them to the nearest health facility. Then there were also, the facilities also do outreaches where they could also be able to capture those who are out of school. Those who were visually impaired or blind, this was one that was quite challenging because the system was very weak, except in Kenya. In Kenya, it's quite strong because they still have the extension or the integrated kind of support there that started through another project. But we tried with working with Parkins International, we worked, and those people they had trained, they would go into the communities and talk to the district leaders, in the district community development leaders and the district population leaders who work with children who are abused or disadvantaged, and then would sensitize them to help us go down and identify some of those children through the village structures, because we have village chairpersons and health officers and things like that. So through the community health workers, the VHT, village health teams, that helped us a lot to reach those out of schools. So that's why it was important to train those people. And the village health team or community health workers in Uganda, for example, actually also follow through the referral process. They also have those referral forms, and they can fill in the form and give it to the parent that they can take to the health facility. And then at that point, that's when the child enters into the health system and then can be worked up to whatever level they can receive the services. And if something that is major, like cataract, whatever, then it gets to district hospital, then they officially refer to the secondary and tertiary level.
Great, thanks, Naomi. And Anne, how about for you?
Yes, because we worked in 11 states, there was quite diverse that the primary healthcare system had attained. In some states, it's quite strong, and one of those states is Cross River State, and in other states at various levels. So where the primary healthcare system was strong, all the primary healthcare workers, a large proportion, if not 100%, were trained on child eye health. And they received children, because immunization is also a very strong, I think, and the service of immunization from 0 to 5 is quite regular. And so what we did was to work with that system, and children 0 to 5 who came to the facilities were reached. They were screened by the trained primary healthcare workers. Then in states where the primary healthcare system is not that developed or strong, village healthcare workers, community-based workers, traditional birth attendants were all trained to screen and to identify children. The screening is not visual acuity, but screening in terms of identifying children with cases. And we succeeded a great deal, because that's how we harvested the cataracts, the congenital eye conditions at that level for onward management. So we had provision for those out of school children. And we were conscious of the fact that I think Nigeria is one of the countries with over 10 million out of school children. So the primary healthcare facility is actually a favored facility to receive children who come for malaria or come for other conditions and are also able to access the care.
Great, thanks, Anne. And it's great that you're kind of looking at all of those different groups who are then connected to the child, and so you're sort of capturing them in those kind of different ways as well.
Add too, Susan, let me quickly add too. We also had groups of children who with displaced parents. We also factored that Cross River State has a huge UN settlement of displaced families. The project also provided care for those children. So nurses who went there, the primary healthcare workers, the primary healthcare nurses, who were all trained, were also at those displaced centers to look after look at those children.
Great, thank you, Anne. And thank you for all of those questions and for those really great responses. I'm aware of time. I would like to ask all of the questions, but I think we're probably not going to have time for that today. So if you do have a question that you really wanted to ask, I'm going to email everybody the survey at the end of this. So you can just reply to my email and then you can ask your question there and I can forward it on to people. So thank you so much for all of those questions, but I would now like to introduce Sally Crook, the Seeing is Believing Programme Manager for IAPB, for some concluding remarks.
Okay, hello everybody, and thank you very much to our 3 presenters and, well, actually 4 presenters, because we also had Simon at the beginning. It's been a great webinar, and I'm thrilled that, you know, we have so many people online to think about this. I think what I would say, the 2 projects, the one in East Africa and the one in West Africa, I think both of them really demonstrated how, even though today we've only really been talking primarily about the, you know, the more community end of things and the screening and the finding the children and then the refracted error services of the preschool and school children, there was obviously all the tertiary care that was required for some children at the hospitals. But, you know, it sounds really easy to deliver services to children, but actually, as all the speakers have mentioned, you immediately get into this issue that you have to deal with both the Ministry of Health and the Ministry of Education, and then the disability sector, however the special schools are, you know, situated in different countries and things. And you end up working with so many people, and then all the NGOs, they all have their different skill areas, and you end up working with all of them. And it just sort of grows like Topsy. And it really has been very interesting in these projects to really be able to provide a service where you're going out looking for your children and identifying children with eye care needs. And then you're having a referral service where you can refer children up. And it's really key that whole pathway works for everybody, especially for the child and the family. And I would say I've seen there have been several other questions around finding the children and referring them and things. And I think what I was very impressed with in all these countries that have been presenting today was a lot of the children did go. And, you know, after the maternal and child health workers or the primary healthcare workers or even the vision champions had told somebody, I think you've got an eye problem, but there is a service provider wherever, near for that particular community, parents really would try and go for an initial consultation, and then if, you know, surgery and other things were required, to really follow up. And I think, again, in a lot of these communities, children having spectacles and, you know, children in schools needing low vision devices and things, it was a brand new idea. And so, you know, uptake maybe was a bit staggered at times, but overall people really welcomed it. And the I would say the primary healthcare staff were also really pleased. And in several countries I went to, you know, the nurses would sort of say, oh yes, I think I actually identified a child who had a cataract, you know, a small baby, a 1-year-old who had a cataract, who was here for immunizations. Or, you know, one of the optometrists saying, yes, I found a child who had really complicated refraction needs and, you know, things. And people were really thrilled that once you gave them the tools, they could actually do a lot to assist these children and help address their particular problems. But it was all very sort of complicated, and you know, if one key person left in some areas, then, you know, it took a little while for systems to get up and running again. But I think the presentations today have shown that actually the governments do have a lot of resources, and they are prepared to include eye care in their school health programs, or, you know, for ophthalmologists to also reach out to do pediatric ophthalmology and things. And, you know, there is often a lot of opportunity to improve both the push and the pull of the service to make sure that children get their services. So I was also asked today, so that's what I'm going to say about the presentations today. I was also asked to just give a quick mention about COVID in this day and age. It would seem a little strange not to mention it, as we're all possibly working from home and things today. And please, if you are looking for any information or resources, please do look on the IAPB website. I know that at the bottom of Susan and my signatures, there's somewhere where you can just click that will take you straight through to the resources on the IAPB website. But I would also say, whatever you see there, please also check with your national governments about what are the you know, the timelines for services restarting and, you know, schools reopening, but all the healthcare services, you know, when are they going to start and things. it will be different in every single country. So make sure that you are fully aware what your country is planning and how they are addressing the issue at the moment. As well as looking at the resources on the IAPB website, please make sure that you've you know, sort of plugged into what's happening at your national level as well, or even in Nigeria at your sort of state level there, and what's happening at every single location. Okay, well, thank you. I've got nothing else to say, so back over to you, Susan.
Thanks, Sally. And thank you to everyone. So I'd like to end today by thanking all of our presenters, Anne, Andrew, Naomi, Simon and Sally, for their comprehensive presentations and responses to all of the questions. And thank you to Rachel for all the technical support. And thank you to everyone who has participated today. We really appreciate you taking the time to be part of our Seeing as Believing learning community. I've just one final favour. I will now email you the Seeing as Believing webinar survey, and if you could please just take 5 minutes to complete it, as your support for these webinars makes them possible and your feedback helps to improve them. So finally, I'd like to thank everybody. Have a great rest of the week, and do keep an eye on future IAPB webinars, because there's a series out at the moment, so do keep an eye out for that. Thanks everyone.
Thank you. Bye.
Thanks, bye.